Hi everyone, my name is Whitney and I'm a PGY1 pharmacist resident at Avera McKinnon, and I will be presenting on metabolic bone disease of prematurity. So this presentation is just going to go over the background of MBD as well as the pathophysiology of how this disease occurs. So just to start with a simple definition, so metabolic bone disease of prematurity is essentially a condition in which a premature infant, or occasionally even in a term infant with biochemical dysfunction, has a lower than expected bone mineral content for their size and gestational age. And some of this can occur with lab abnormalities, which typically occur first, as well as radiological findings such as fractures. So some risk factors, so when baby is still in mom, some risk factors would be any type of placental insufficiency, so that could be preeclampsia or even choreo, as well as some other things that are listed there. And then postnatal or after birth, other risk factors would be prematurity, so neonates that are born less than 28 weeks of gestation, as well as very low birth weight, or a birth weight that is less than 1,500 grams, and then again, anything lower than that is going to be even at higher risk. Additionally, prolonged TPN is a risk factor. Now that's mainly due to not being able to supply babies with enough calcium and phos in a TPN without it precipitating. So that puts them at risk, as well as some other diseases that are more immature in infants, such as BPD, so the lungs, as well as neck, so the intestines, and then some immature liver and renal diseases. And then medications that could potentially cause MBD are loop diuretics or glucocorticoids. So now moving into clinical signs. So most of these have to do with the fracture risk for these infants. So increased work of breathing. This is mainly due to infants who are born less than 28 weeks still have cartilage bones. So once they start to form strong bones, they're more frail and easily fractured, which could increase their work of breathing. Additionally, you may see enlarged cranial sutures, some frontal bossing, and then later on down the line, you may see some rickets, and then again, multiple fractures potentially, as well as postnatal growth failure. Now, most of these clinical signs don't appear right away. It may take up to 5 weeks to see any signs, but some early detection is noted that could be around 2 to 3 weeks of life. Now let's talk about in utero. So what kind of transfer do we see with calcium and phosphate between mom and baby during utero? So the third trimester is essentially where a majority of placental transfer of calcium and phosphate occurs, and that's between 29 weeks and 40 weeks. So babies who are born preterm will be deprived of this accumulation. So to put that into perspective, so at around 25 weeks of gestation, infants are getting about 60 milligrams per day of calcium and phos. However, once they reach that third trimester, about halfway through, they're going to dramatically increase those mineral contents. So the calcium rate per day is 100 to 130 milligrams per kilogram per day for mom, and phosphate rate is going to be 60 to 70 milligrams per kilogram per day for mom. So to discuss why the placental transfer of calcium and phos is important, well, mainly due to bone development. So on the bottom there on the left, that picture is of bone development. So it starts with the primary ossification process as well as moving into secondary ossification. So calcium and phosphorus are very important in building strong bones. So on the way left there, initially, typically even in the first trimester, baby starts to build cartilage, which is the first process into building bone. So as it goes down the process, it turns into a primary ossification process, which that is when it starts utilizing calcium and phosphorus to start from the inside of the bone and starts making strong bone moving outward. So continually into the second trimester, and then once it reaches secondary ossification is when you kind of get into that third trimester where you see an abundance of calcium and phosphorus from mom to baby. Now this is very important because this is kind of an accelerated bone formation time for baby, especially for epiphyseal plates or growth plates. So this is why babies need that hypercalcemic environment from mom during that third trimester to make sure that this bone formation process occurs. And then most of that, if you look on the right there, so in utero, baby's going to get their calcium and phos from mom. However, if they are born prematurely, they are going to have to rely on intestines and kidneys, which in premature infants sometimes are immature. So they have to rely on those two to kind of replicate what they would get while they were in mom for the rest of that third trimester. So now let's discuss in utero fetal hypercalcemia and why this is important in the third trimester for baby to build strong bones. So you have your initial increase in calcium, and the calcium sensing receptors notice that this calcium is increased, and it's going to tell the parathyroid gland to stop producing so much PTH, as there is a indirect relationship between these two. So when calcium is high, PTH is low, and vice versa. So if PTH is decreased, then this is going to decrease, it's called 1-alpha hydroxylase, which is the enzyme that breaks down inactive vitamin D into active vitamin D, which is calcitriol. Additionally, it's going to increase 24-hydroxylase, which also prevents breakdown into the active form of vitamin D. And then FGF, or fibroblast growth factor, also plays a part in this role just by kind of exacerbating both that 1-alpha hydroxylase and that 24-hydroxylase to additionally decrease vitamin D. So how does baby overcome this? Well, when in utero, it produces what's called PTHrP, or parathyroid hormone-related protein. So this essentially mimics PTH, however, is not affected by calcium levels. So it can constantly be increased and constantly produce more calcium or increase more calcium despite PTH being pretty much zero in these babies. So you'll see increased calcium, increased phos, which allows a great environment for increased bone formation. To reiterate again, babies in utero during the third trimester are bathed in an extremely hypercalcemic environment. Additionally, calcitonin will be increased as well. Now, it does decrease calcium and phosphate, which may seem counterintuitive. However, what calcitonin does is it's going to inhibit osteoclasts. So one of PTH's ability to increase calcium is to break down the bone and release calcium that way. However, with increased calcitonin, it's going to prevent those osteoclasts from breaking down bone, which not only allows baby to form healthy, strong bones, but also prevents the breakdown of those strong bones as well. So if a baby is born prematurely, then this process is interrupted. Now just to go over a few key takeaways from what we just talked about for in utero transfer of minerals. So during the third trimester, typically between the weeks of 29 and 40, baby's going to require a lot of calcium and even phos to build strong bones for that secondary ossification process, which mom is going to supply to them through the placenta. And then 2, so if baby is born prematurely, so before that third trimester, roughly less than 28 weeks, they're going to be deprived of that hypercalcemic environment, and they're going to have to try to mimic that through immature kidneys and intestines outside of mom. And then 3, PTH and calcium are indirectly related. So if, for example, if calcium is low, PTH is going to be high, and vice versa. This slide here is just for your reference. I will not go through it, but it may be something that you may want to review on your own time. So now let's discuss postnatally. So we just talked about baby while they are still inside mom, and now we will talk about what happens after birth. So levels of calcium, phosphate, and PTH after birth. Now these diagrams depict a term infant. So typically at birth, since we've talked about baby will be in a hypercalcemic environment, once mom does give birth, baby's calcium levels will start to drop, typically within the first 24 to 48 hours. And as we see that drop, if you look to the way right, you will see that PTH will start to rise. So they, like I said, indirectly related. So as calcium drops, PTH is going to rise, and then you'll see an initial homeostasis, typically around 48-ish hours, as term infants' parathyroid gland is a lot more mature than term infants. And one of PTH's roles or mechanism to allow for increase in calcium is to decrease phosphate. And the reason for that is to reduce the precipitation in the blood of calcium and phosphate. So it will increase calcium reabsorption in the kidneys, and it will increase the excretion of phosphate in the kidneys as well. So then you'll see that initial slight decline in phosphate as well in term babies. Now, what happens with preterm babies is that they do still have that initial drop in calcium. However, it continues to prolong as they are requiring more need for calcium. Their parathyroid gland is most likely immature and not able to balance out PTH and calcium. Their kidneys are maybe not mature, so they don't reabsorb calcium as easily. Additionally, they just require more calcium due to needing more bone growth or formation that we've just talked about. So as calcium continues to be low, PTH will continue to rise as it's trying to combat for those low calcium levels. While as PTH continues to rise, you'll see a continued drop in phosphate as well. So some net changes you may see is hypophosphatemia, which is going to be your phosphate deficiency or decrease in phosphate levels. Additionally, hyperphosphatemia, which I will discuss shortly, but that is an increase in your ALP, which is your bone turnover level, as well as secondary hyperparathyroidism, or an increase in PTH. Now, due to that increase in PTH, we are able to see phosphate levels decline earlier, and that might be your earliest biomarker to determine if a baby is transitioning into metabolic bone disease of prematurity. However, there are a multitude of different biomarkers that I'll discuss as well. So now that we've discussed kind of the levels at birth, let's discuss the hypocalcemia environment and what that looks like in a term infant and how they balance out their calcium and PTH. So the parathyroid gland notices that there's hypocalcemia, so it's going to increase its PTH. So as we've discussed previously, increased PTH is going to increase calcium resorption in the kidneys, so you'll see an increase in calcium plasma levels, and it's also going to cause phosphate wasting in the kidneys, so you'll see a decrease in phosphate. So net effect, increase in plasma calcium levels. PTH also is going to increase that 1-alpha hydroxylase that we've talked about, which is that enzyme that breaks down inactive vitamin D into active vitamin D. Which what active vitamin D does is it helps to improve the absorption of calcium and phosphate in the intestines. So through increased calcium in the kidneys, as well as increased calcium and phosphate in the intestines, we have a great environment for continued bone growth in a term infant. One other thing to notice is that it is a negative feedback loop. So once the body realizes that calcium is getting too high, it will have a feedback loop to decrease PTH. And good thing is that term infants have a mature parathyroid gland and are able to balance out this system continuously. One last thing is that vitamin D can also play a role in a negative feedback loop with the parathyroid gland to help reduce PTH as well if needed. So just another thing to keep in mind. So net effect of an increased PTH is going to be hypercalcemia as well as hypophosphatemia, but in a term infant, this is completely normal and they're able to balance it out appropriately. So what would happen in a premature infant? And now that we've discussed how hypocalcemia is balanced with term infants, let's discuss how that works with a premature infant. So process is essentially the same. Still will go through the kidneys as well as the intestines. Again, one thing that might be different is that premature infants might not have mature kidneys as well as they may not have mature intestines. So the reabsorption of calcium may be inefficient, as well as the absorption of calcium in the intestines may also be inefficient. So with both of these attempting to increase calcium levels, the one difference here with term infants as well is that they are going to require a lot more calcium and phos to increase bone growth. As we've talked about, during that third trimester is when they get a majority of their strong bone formations. So what we see is that negative feedback loop that is typically balanced in a term infant is not going to be balanced in a premature infant, which may lead to prolonged increase in parathyroid hormone or PTH. So it'll continue to try to use the kidneys and the intestines to produce higher calcium levels, but at some point, last resort for PTH is to attempt to pull calcium from the bone with bone resorption. So it's going to cause more osteoclast development, which is going to break down bones that were formed by baby to release more calcium, as that's where about 99% of our calcium is stored, to try to improve the calcium plasma levels. So with that, we kind of get into this vicious cycle of baby getting strong bones from increased calcium plasma concentration, and then you'll see that it's not enough, so then it has a lower plasma calcium concentration, so then PTH is going to steal that calcium right back from the bone. So this is where you get that increase in bone turnover or continued formation and breakdown of bone in premature infants. So just some key takeaways from those two pathways, so term versus preterm. So in a preterm infant, calcium and phos requirements are going to be a lot more than those in term infants due to attempting to turn cartilage into bone. Additionally, you may see immature parathyroid glands in preterm infants, which dysregulates that calcium and PTH balance. You may also see immature kidneys and intestines, which is going to kind of limit the amount of reabsorption of calcium that we get, as well as decrease the absorption of calcium and phos, which kind of all play in a part of that vicious cycle we've just talked about. One thing I want to point out is that prolonged increase in PTH results in overriding the kidneys and intestines' ability to increase calcium and resorts to pulling stores from bone. So we've kind of discussed that, how preterm infants have more calcium pulled from bones than term infants just due to the excessive calcium that they require to build those bones in the first place. So now let's discuss biomarkers and what these look like in patients who may be progressing into metabolic bone disease. So we'll start at the top of the graph here with PTH, or parathyroid hormone. So this is typically high in infants who are suffering from metabolic bone disease due to it trying to combat hypocalcemic levels. Now this is kind of counterintuitive because despite calcium levels potentially being normal or even high, we know that these infants are still having hypocalcemia due to them trying to pull calcium from the bone, which then is going to increase our plasma calcium concentration, which is the lab that we typically get to go off of. So it may look like we have a normal or high calcium level, but baby is probably trying to pull calcium from the bone, which is causing more problems. Additionally, with PTH being high, it's going to try to increase the excretion of phos to try to have that equilibrium between calcium and phos in the blood to prevent precipitation. So you may see that as low as well. Additionally, TRP, or tubular resorption of phosphate, you may see as high. This typically occurs when PTH is prolonged for a pretty long period of time. So it is continually excreting that phosphorus, and then at some point the body actually realizes that it's in a hypophosphatemic environment, so it's going to try to resorb more phosphate in the kidneys. So at that point, when you do see a high TRP, you know that the body is in a hypophosphatemic environment and we maybe need to replace with phosphate. Additionally, ALP, or bone turnover, alkaline phosphatase is used as a marker for bone turnover. So essentially, if baby is going back and forth between forming bone and breaking down bone, that's when this level increases. Additionally, vitamin D. Now, vitamin D may be low in patients with metabolic bone disease due to rapid bone turnover, which requires more vitamin D storage in an attempt to improve calcium storage. So that's again why this level may be low, is due to a depletion of vitamin D. And then again, calcium is not an ideal marker to use just because it may be normal or even high in some infants who are suffering from hypocalcemia. One thing to note is that you may see biological markers that I just talked about usually before any radiological findings as well, so like any fractures or things like that. To wrap up this presentation, here's just some key takeaways. So 1, baby is going to require a lot of calcium and phos during that 3rd trimester, so typically between the weeks of 29 and 40, due to being in an accelerated bone formation state or during that secondary ossification process. 2, PTH and calcium are indirectly related, so when one is high, the other is going to be low. 3, calcium is not an ideal marker to determine mineral needs. Now, we kind of went through that with the pathophysiology, but calcium can seem normal or even high, but a preterm baby might be pulling that calcium from its bone into the serum, making that level not accurate. 4, low phosphate with a high TRP, or tubular reabsorption of phosphate, indicates hypophosphatemia or low phos. 5, lab abnormalities may manifest before radiological findings. So you may see some differences in labs prior to seeing any fractures on x-rays or things like that. So one big idea that I want you to take away from this presentation is that babies who are born premature, so less than or equal to 28 weeks, are not supplied with enough minerals outside of mom to properly transition cartilage into strong bones, which ends up leading to a vicious cycle of bone formation and bone breakdown to help balance plasma calcium concentration and bone calcium concentration, which leads to frail, easily fractured bones in premature neonates. And here are my references that I used for this presentation. And that wraps up this presentation. I appreciate you listening, and I hope that this was of benefit to you. Thank you very much.